I'd like to welcome our panelists. We have Dr. Taylor Buck, we have Mary Oliver, who is a genetic counselor, and then Nicole Wright as well. And Nicole is just here at Grand Valley now. So I will let them finish their introductions, and thank you all for coming. At the end, I will be handing out certificates. So if you're looking for IPE credit, you will need that certificate. Thank you so much.
I feel like I should stand. What's up, peeps? How does peeps translate in sign language? I was just curious.
Yeah, it's just like people.
People? Okay,
Yeah.
gotcha. I'm so thrilled. This is hysterical because we're going to be talking about genetics, so I feel like this is like a board test to like do chromosomes, genes, DNA, all that stuff. I'm Caleb. I'm a medical geneticist, and we are going to sort of start out by at least kind of just sharing sort of our story just briefly, and then we're going to give a go at kind of running a mock scenario for you guys about how genetics kind of fits into the bigger picture of a variety of healthcare specialists. Is there always pizza at this thing?
Yeah.
Okay, gotcha. I watched some of the streams from the early ones, and I tried to like count the heads, and I feel like there are more people here tonight, so I thought maybe like pizza was a treat. So we're not quite as special as I thought we were. I am a geneticist, and let me tell you how I got to becoming that. I was a molecular biology major in college, mostly because people said that you're smart, so you should like go into science, but I had no clue what I wanted to do with that. My dad was a dentist for kids, and especially kids with special needs, which is kind of funny that I've come full circle in many ways. So I always very much pushed back against the idea of like doing something health related, because I always felt like I would like just be doing whatever my dad did. And it's weird to this day to like hear people call me Dr. Buck, because that's always going to be my dad. I lived in the South for a couple years, and there I was Dr. Buck. And that felt a little different. I felt like I had my own identity for a couple years. That's all I know. So I was a science major in college. I did a medical mission trip in between my somewhere in college, and went to Kenya for 2 weeks. Worked out of a dirt floor clinic, just sort of serving people with very rudimentary healthcare, and that was sort of my moment of zen, or whatever you want to call it, where I was like, yeah, I guess this is what I want to do with my life. So I then went the route of medical school, and when I was in medical school, didn't really have a good sense of what exactly I wanted to do with that. And almost by process of elimination, I ended up heading towards pediatrics, mostly because when kids are sick, it's usually not their fault, and adults are kind of terrible. You know? I went into pediatrics, and what that is a residency, so a 3-year residency in pediatrics. And during that, I ran into patients that had genetic conditions, so like kids that were born with genetic conditions. And it was fascinating to sort of see the genetics professionals, which we're going to try to give you a simulation of this tonight, come and meet with these families and meet with them in a unique way. It was very specialized, but really had a lot of meaning. To the patients, to the families, etc. And so that then steered my course to genetics fellowship. So then I did 2 more years of genetics training to finish my education at the ripe old age of, how old was I? I would have been like 30 when I was done. I think I did like 20 years of school or something like that. It was a long haul. And certainly you're in the midst of that with your variety of courses. And it's hard sometimes to kind of know what the right route is for you. So I've been here in Grand Rapids for 4 years, practicing at Spectrum, which is kind of like Spectrum / Helen DeVos, working in the genetics clinic. And what we do in genetics clinic is see people who have genetic issues. And that's a pretty like generic way of saying things, but it's actually the truth. And I think it's one of the reasons I really like genetics is because there's so much variety. So we see people who have birth defects. We see people who have genetic conditions, like someone who has Down syndrome, like that's caused by an extra chromosome 21, in case you didn't know. We see people who have that. We see people who have something like autism or learning problems that like might be genetic, that we're not necessarily sure. We see people who are adults who have muscular dystrophy or who are starting to have balance issues, movement disorders. But then we also see people who have a family history of something. Like my uncle had cerebral palsy. What's the chance that my kid has something? We see women who are pregnant and the pregnancy ultrasound has something unusual on it, or there's a family history something. Am I forgetting anything else? We see everything under the sun, which is absolutely terrific, and it's one of the reasons that I think genetics is the best. And hopefully you will leave here from this evening with a plan to change your career. Other than the people that I hear in the genetic counseling club, they obviously are on the right track. So I will shut up and I will let Mary and Nicole introduce themselves and give you some sense of who they are and where they came from.
So my name's Mary. I'm a genetic counselor. I work with Dr. Bob, but I actually never heard that story about how you have to be a geneticist. So that's kind of
I'll never tell it again.
So let's see. So in undergrad, I like science. I feel like a lot of genetic counselors kind of start that way. They just know they like biology and they want to do something in it, and they just kind of go through undergrad like that. By the way, I just want to get a sense of who's in the room. Do we have undergrad and graduate students here? Who's undergrad? Okay, and who's graduate students? Okay, so it's a little bit of a mix. I just wanted to get a sense of where everybody was. So it wasn't until my last year I heard about genetic counseling. Sometimes I feel like when you're an undergrad and you like science, you feel like you have to go get your PhD or you have to go to med school. And I felt that those were my only options. That's what was kind of presented to me. When you look up different things to do, I feel like that was what I kept coming back to. But I knew a variety of things in it. I didn't want to go to school that long. I knew that I didn't want to work in a lab. I didn't want to have a pipette in my hand for the rest of my life, kind of things like that. So I heard about genetic counseling my senior year, and it just kind of fit everything I was looking for. Working with people, working in healthcare, working in science, and an area of science that's always changing. And I hope you guys will get a little sense of that tonight, that it's always changing and you really have to stay on top of the new research that's coming out. So it kind of hit all of those. And then I took the dreaded gap year, which I know a lot of people are worried about, but for me it was really great. And I applied to U of M and went to that program. Was there for 2 years, and then I came back to Spectrum Health, where I work in medical genetics. And actually, I'll just let y'all know, today was my last day at Spectrum, so it's kind of a weird day to come and do this presentation, but
She didn't get fired.
I did not get fired, no, I took another job. Yeah, I didn't get fired, it just happened to be today, was my last day there. But let me tell you a little bit about what I did at Spectrum. So I saw all the same patients that Dr. Buck was talking about, and then I also specialize for everybody who has cystic fibrosis in the area and they come to clinics. Does anybody know anybody with cystic fibrosis? Yeah, pretty common, so a couple of you have seen them. So I see babies, infants, pediatric kids, and then adults with cystic fibrosis. So it was really cool to specialize in that syndrome and then to see people across the lifespan, all the different issues that come up and counsel and kind of help people through their whole life with the condition. So my new job, which I'm starting on Monday, I'm going to be working for a genetic testing company, and I'll be going to OB offices and talking to providers there about the genetic tests that they offer. So it's very different, but I'll still be a genetic counselor in that company, and just a lot more of the business side. So there's a lot of things that genetic counselors do just besides working in a hospital, and I'm going to get a little piece of that on Monday. So.
Okay, so I'm just going to stand over here instead of walking at the podium. So my name is Nicole Ray, and I was put by Nikki. I have similar story, kind of echoing a little bit about what Mary said. I was actually a student at Grand Valley. I got my undergrad here at Grand Valley, so lovely place. And at the time when I started Grand Valley, same thing as Mary, didn't know what I wanted to do, but I enjoyed science. I enjoyed healthcare, didn't want to be a doctor because I didn't really want to go to school for 20 some odd years. But I really wanted to work with people. I thought social work was rather interesting as well. So it wasn't until the end of my junior year here at Grand Valley, one of my biopsych courses, that we watched an old video from like 1990. And it showed this genetic counselor with these huge 80s glasses on, big poofy hair. And I'm like, genetic counselor, what the heck is a genetic counselor? So I went home, Googled it, I'm like, I think I might like this. So I did a little bit more research on it. I actually shadowed with some genetic counselors at Spectrum at the time, and then decided at that point on, I was kind of sold that I wanted to continue on with genetic counseling. So I went to Wayne State and got my master's degree at Wayne State. After Wayne State, I went to Bronson down in Kalamazoo, and I worked there for 5 years in prenatal genetics. So prenatal genetics is obviously, when you graduate as a genetic counselor and you pass your boards, you are qualified to work in any specialty of genetics. So I just want to kind of clear that up. I actually thought I was going to go into cancer genetics. I loved cancer genetics. I loved helping families out when it comes to more of the psychosocial aspect of a cancer syndrome in the family. But a job opened up in prenatal genetics. I'm like, okay, I'll give it a go. And I ended up loving it. So I worked at Bronson for 5 years before Grand Valley convinced me, after about a year of trying, to come up here, and I'm now an assistant professor here in the Allied Health Science program, pretty much in a way to try to get a graduate genetic counseling program up and running here at Grand Valley. So that's the kind of the end game here. So as a prenatal genetic counselor, some of the things that I saw were more obviously women that were pregnant, but also preconception. So if there's a family history of cystic fibrosis or sickle cell disease or something called Fragile X. Has anyone heard of Fragile X? So if somebody was a carrier of a condition and they wanted to know what the chance of them having a child with that condition, or if they had a brother or a sister who had a condition, what's the chance of my child having that condition? And sometimes it could be as simple as me just looking at the referral and saying, oh, well, this is just a family history paternal, so on the father's side, family history is Fragile X, and we know that Fragile X is an X-linked condition, and fathers don't pass that condition on to their offspring unless they are actually impacted themselves. So just something as simple, it could be a very quick session, saying, no, you're not at an increased risk over the general population, or it could be a lengthier consult where patient comes in just for her normal 20-week ultrasound, which is typically when you see all the baby's anatomy, and most people think of that time period as a time for moms and dads to find out gender, so male or female, but I'll tell you what, they spend about 45 minutes looking in great detail at that baby from head to toe, and if anything looks concerning, then that's kind of where a high-risk OB or genetic counselor kind of come in and explain what that means, explain some of the testing options, some of the risks of the baby. And part of the reason it's helpful to have a genetic counselor present is that I have a bit more time to sit down with those patients and really kind of tweak through where those patients are coming from. Not everybody wants to do additional genetic testing during the prenatal setting. For a lot of patients, they say it's not going to change anything for me if I find out that my baby has Down syndrome now versus after my baby's born. Some families don't even know what a genetic condition might be that we're seeing on an ultrasound. So my role is kind of, is any genetic counselor's role, is to kind of act as a detective and try to put pieces together for what a condition might be. So the testing that you offer prenatally is going to be different than some of the testing that you offer in like a general genetics clinic where you have the patient sitting right in front of you. So I loved working as a prenatal genetic counselor, and I also enjoy teaching. So it was kind of a hard call to kind of change that career. But at the same time, I love that as my schooling actually provided me to have those opportunities to do more than just work in a hospital clinic setting. As Mary said, she's working more on the laboratory side. So you can see that for genetic counseling or just genetics in general, there's wide settings that you can work in. And there's only more and more opportunities that are opening up with kind of the advances in technology that we have. So I will kind of give you a heads up just right now that with my background as a prenatal genetic counselor, the skit that we're doing is pediatrics. So I have not done a peds consult since about 2012. So that shall be fun. All
right, so we're going to try to keep this a little bit interactive. So I know we're all incredibly attractive, and you can look at us for an hour, no problem. But we want to try to engage you a little bit. So we're going to run a scenario that hopefully shows you how genetics fits in to a wide variety of other health professions and how we use information that comes from other people from various places. So what we have is we need some audience participation. So we have 12 different roles that I need people to volunteer to just read like a short paragraph. I promise it's very painless. And they are divided up by like specialty. So I thought if like someone might be doing something, they might be willing to read it. So is anyone interested in becoming a nurse practitioner, or maybe they wouldn't be sad if they ended up as one? Okay. What about something in like imaging, cardiovascular sonographer or something like that? Would anyone just, thank you very much. PT or OT? Oh, thank you, thank you. I combined them together, and I know every physical therapist and occupational therapist would tell me that's wrong. Speech therapy? Thank you. And I talked to some speech therapists about this yesterday, and they picked it apart, and I'm very sorry, it was very inaccurate. Nursing, I saw nurses, there you go. Anyone like in the lab at all?
Medical lab sciences?
Medical lab sciences? Thank you. I have a physician assistant next.
We have to have some PAs in the room. Group PA, anyone?
Would someone,
Did I see a half hand raise?
okay, and you can raise your friend's hand too. Don't read what's inside. I'm about to say that to his face. Dietitian?
Any clinical dietetics? Anyone?
Raise
Anyone
your hand.
interested in nutrition?
Thank you. Pharmacy? Oh, there we go. There's some very reluctant hands. I have another like stenographer one. I'm not like downplaying that. Here, you're right in front of me. Social work? Social work, and then I have public health. Which one are you taking?
I'll be social work.
Will you take public health? Yeah. Beautiful. All right. So we have not rehearsed this one bit, so this may be super ratchet. Just roll with it, okay? All right. So we're going to start in the beginning, and I'm going to be the narrator, and then Mary and Nicole are going to play the central protagonist and antagonist in our play. And we'll get to their part after we sort of build a little backstory. All right. So this is a scenario. So you are the parent of a 15-year-old female who has autistic-like features. So some behaviors, some quirkiness, maybe on the spectrum, etc. And your daughter wants to participate on the school track and field team and went for a sports physical. So we're going to start with the nurse practitioner. And I have this set up because we're trying to encourage participation. Each person starts with, "Hi, my name is," and then you say your real name. And then you say what role you're playing. And then you have to pause. And all the audience is going to say, "Hi, your name." All right? So we'll practice together. So, "Hi, my name is Caleb, and I'm playing the role of the narrator."
Hi, Caleb.
Look at that. Look how well you're participating. All right? Okay. So we have the scenario crafted. Who is my nurse practitioner? Please tell us what's going on. Yeah, you just stand up there. I don't like to share the stage.
Hi, my name is Kristen, and I'm playing the role of a nurse practitioner.
Hi, Kristen.
So I saw this patient for her physical and noted her to be tall and very slender. When I was listening to her heart, I noticed that her chest wall was a little misshapen, and I know this is called practice excavat. I heard in the news and I've read articles about kids dying from cardiac arrest playing sports, so I have a pretty low bar for having my patients get worked up for heart problems. I decided to send her for an echocardiogram.
All right. So that's where we start. So our next person is going to be the cardiovascular sonographer. Who had that one? All right. Don't forget to read the. Okay.
All right. Hi, my name is Nadia, and I'm playing the role of cardiovascular sonographer.
Hi, Nadia.
I met this patient when she came in to get her echocardiogram performed. When I was looking at the order for the test and why there was concern, I thought that I should make sure I get good images of the aortic root because some genetic conditions don't cause any issues with the actual heart but can cause the aorta to be dilated. I didn't notice anything unusual when I was performing the echo, and the cardiologist did read it as completely normal.
Thank you. So, just an aside here, this is a very legitimate patient scenario. Like, this isn't like fantastical or made up. This is very often how patients end up coming to us. So, as a parent, you're still concerned about all this. And you've heard a lot about autism being on the rise or increasing lately. So you caught a special on the Discovery Channel about genetics, and you're starting to have trouble with insurance in your daughter's school covering her therapies. All right? So let's hear from the physical and occupational therapist a little bit more about that.
Hi, my name is Erica, and I'm playing the role of the physical and occupational therapist.
Hi, Erica.
I've been working with this patient for many years because she has had developmental delay. When she was younger, we worked on gross and fine motor skill development. We also worked on tasks that she would need to be successful in school, like writing. I've always provided detailed assessments to her family and her school to help her with her IEP. Lately, as she has gotten older, her school has been more reluctant to allow her to maintain her services, saying that she has aged out of them. My office has also had some trouble with her insurance, limiting the number of sessions that she can have with me. I have written letters of support for her family as they have advocated for her to school and insurance, but it continues to be challenging.
All right, so in that vein, we also have an update from the speech therapist who's over there.
Hi, my name is Carissa, and I will be playing the role of the speech therapist.
Hi, Carissa.
When the patient was about 3 years old, there were some concerns about her potentially being diagnosed with autism. Her family struggled to find somewhere to get her evaluated for autism, where her insurance would recognize the diagnosis. One of the reasons for trying to get an autism diagnosis is that it would help her to qualify for ABA, the Applied Behavior Analysis Therapy. It is a very time-intensive therapy that can help autistic children with the communication skills. Without an official diagnosis of autism, she was never able to get that therapy.
So we have all this information coming together, things on the physical exam, went for an echo, information from the therapists, and so you as the parent follow up with the nurse practitioner about the normal echo, and you ask about what additional workup we could do for this genetic for the autism. That particular nurse practitioner has been to a fascinating, riveting, and life-changing pipes lecture about genetics and suggests referral to the genetics office for evaluation. So we sort of built the stage, and now what we are going to attempt to act out is a genetic counseling appointment evaluation, however you want to say it.
Hey, my name is Nicole. I'm a genetic counselor here. How are you doing today?
Well, how are you?
Good. So tell me a little bit about what your understanding is for why your physician wanted you to see us today.
Well, it's about my daughter. She has some autistic features, nothing really else, and I just think that she needs some sort of test for genetics, and I'm just really concerned about that. And so her provider just told me to come and just see what you guys can do for her.
Okay, well, hopefully by the time that you leave here, we'll be able to answer a little bit more questions. We can go through and talk about just genes in general. We can talk about potentially how different conditions are inherited. And you'll also meet with our geneticist today, and he'll do more of a physical exam for her. What's your daughter's name?
Rachel.
Rachel? Okay, so for Rachel, what I'm going to do is also ask a few questions about kind of development for her, and give you some information about family history, and then try to piece some information together. And if at any point you have questions, don't hesitate to ask those. Okay, there we go. So tell me a little bit about Rachel growing up in terms kind of like from the time that she was born. Did you have more of a routine pregnancy with her? Are there any complications?
No, it was a really normal pregnancy. Nothing on ultrasound. I did have some initial testing for like the Down syndrome test, you know, and that was all normal. And the birth was on time, and only in the hospital for a couple of days.
So a lot of times families are kind of told by their OB or midwife that the types of screens that they have during pregnancy can screen for multiple types of genetic conditions. But really they kind of focus more on more of the big picture items, so things like Down syndrome or kind of lethal types of chromosome conditions or even something called spina bifida. But there are thousands of other conditions that just aren't screened for during pregnancy. But it's good that you kind of had that information during the pregnancy. So after she was born, tell me a little bit about, was she a good size when she was born? Do you know how many pounds she was?
Ooh, that's a long time ago, but like right around 8 pounds, I think. Yeah.
And tell me a little bit about some of her milestones. Did she walk? What time did she walk at? What time did she crawl at? Things like that.
Well, she was a little bit behind in everything, but always, within the scope, just at the very end of normal is what everyone kept saying. So walking and talking, definitely after age 1. So by age 2, I would say, is when she kind of mastered walking. Talking was a little bit different. But I always felt like she caught up with her therapies, but definitely behind. And when I compared her to my other children, behind.
And I have here in her chart that she has seen speech-language pathology. Can you tell me a little bit about that?
Yeah, she's been seeing the speech language pathologist for a long time, and she's had very she's always improved with that over time.
And then in terms of her history of developmental delay, who ended up diagnosing her with that?
I think it was her primary care who was first concerned, and I think there might be some specialist. It was over at the big hospital, like a neuro or neurology, maybe something like that, where they had, but then I haven't seen them in a long time.
How old was she when that happened?
Probably around 3.
So one of the other things that I like to do is just kind of give a family history to see if there's anything else going on that we're unaware of. I'm actually going to write it on the board. I usually don't do that, but that way you guys can kind of see a little bit more about a pedigree. Has anyone done a pedigree before in class? Show of hands. I see the genetic counseling club always in there. Who in here, sorry, this is completely breaking off straight. Who in here has had a genetic course before? Good. Who has had a biology course before? I think all of you, like, Bio 120 is pretty much required. Okay, so somebody just real quick tell me what would be a symbol for male? Where? Female? So if I'm going down, what would that be? Okay. And then Mary, you said that you have other children. How many other children do you have?
I have 2 other children.
Okay, do they have the same dad as Rachel?
They do.
Boys or girls?
I have 2 sons.
Okay, are they older or younger than Rachel?
One older, one younger.
Okay, how old is your oldest?
19.
19? And what about your youngest? 12.
Sure, 15 sounds good.
Okay. And for your son, who's 19, any health concerns for him, any developmental delays? Do you have any concerns about his milestones that you
No, I mean, he has asthma, but it's really been the only thing for him.
And then what about for your youngest son?
No, nothing at all.
Okay. Anyone in the family have any concerns with vision problems, so anything called myopia or?
I mean, I wear glasses, but that's all of it.
And then for you, any specific health concerns that you're aware of?
No, I just have PCOS, but that's it.
Okay. And then do you have any brothers or sisters?
I have 2 sisters.
Okay. Are they full siblings? Same mom and dad?
No, one full and then one's half through my dad.
Am I getting too detailed here? It's just like, you just start asking questions and just start, okay.
This is, to be honest with you, this is like eerily realistic. They're doing a fantastic job. This is exactly how it goes.
Which is weird, because I haven't had a consult on
Yeah.
this, so.
And Mary just threw her a curveball with the different dads, because that always is annoying when you're drawing a pedigree.
It'd be much easier if you could just do the priorities board. Okay, so you said that your sister has, one has a same mom and dad too, but your other sister has a different dad than you?
Same dad, different mom.
Same dad, different mom, okay. I apologize, I'm kind of coming behind here. Okay, and we're just gonna, just for sake of time, just focus on the paternal side here. Does your full sister, so a sister that have the same mom and dad, do they have, or does she have any children?
No, she doesn't.
Okay. By choice, or has she had complications?
She doesn't really talk about it that much, but she just recently got married, so.
Okay,
I just
okay,
have
so
to-
still
yeah.
kind of early stages.
Yeah, I think so.
What about your sister where you guys have the same dad?
Yeah, she has 4 children.
4 children?
Mhm.
How many boys and how many girls?
2
with her?
boys and 2 girls.
Any health concerns for either of them?
Not that I know of for them, no.
Okay. And then outside of health concerns, so a lot of times when we say health concerns, we might think of something physical. Anyone have any type of cognitive impairment or delays in school that you're aware of?
Just like very distant family members, but nothing in my immediate family.
And then the next question is going to sound kind of funny, but do you know where your ancestors are from? Are you the Dutch or German?
I did that test.
You did like ancestry DNA
Oh, I
or
did.
something? Oh, of course you did. Okay. So what did it tell you? That's very realistic too, just so you guys know. People come in and have a whole list of ancestry.
Yeah, I mostly Norwegian.
And on to the Olympics, right?
Yeah. And then do you know for, is it husband, fiance, boyfriend?
Oh, my husband.
Husband, okay. Does he have, does he have any idea of his ancestry?
I think he's probably Dutch. I'm not, he didn't do the test. so
More
I'm
of
not
a
sure.
mixture of European
Yeah,
ancestry?
yeah.
Okay. Okay. Now, looking at your family history, there's really nothing that jumps out, but that doesn't necessarily mean that there's nothing hereditary in the family. Sometimes there are conditions that are de novo, meaning that it's a new condition just for Rachel herself, or it could be something that parents are possibly carriers of, which means that they are completely unaffected, but if two carriers get together and they both pass on those traits, then that child could potentially be impacted. Hang on, let me make sure I'm following the script here. Perfect. So now, when it comes to some of the different tests that we can offer, looking at the family history and the fact that Rachel's 15, it's unlikely that she has any major chromosomal concern. So if you think about our genes, think of it kind of in a way as a bunch of encyclopedias. And if you have all of your encyclopedias in a row, so A through Z, I understand we don't really use book encyclopedias anymore, everything is online, but let's say that you still have all those book encyclopedias. A chromosome abnormality might mean that a whole encyclopedia is missing. So if you have a whole chapter of your genetics missing, that has larger global impact. So multiple birth defects, sometimes babies might pass away in the womb. Sometimes you might have significant cognitive impairment, meaning not that they're just delayed, but you might have lower IQ. That's very obvious. Now, if you break it down even more, you could have, instead of just a chromosome abnormality, maybe you have a piece of your chromosome missing. So think of it kind of as like multiple sentences are missing, or maybe a paragraph is missing or added to your genetic kind of instruction manual. If something like that happens, it's not as obvious, might not have more of a global impact, depending upon if it's a very important paragraph or a not so important paragraph. And then you can kind of break it down even more. Maybe you just have a single word missing, but maybe that word is really important to how a specific aspect of the body is developing. Sometimes it could be something as simple as a protein isn't developing properly, or maybe your metabolism isn't functioning properly. So there are different levels of genetic testing that we can offer. Typically, we try to start off by looking more at a big picture item, and then you kind of narrow it down at that point. So after you meet with our geneticist, he will kind of do more of, like I said, the physical evaluation for Rachel. And if something comes up that he's more suspicious for one specific disorder, we might just look at just that one word. But a lot of times we might try to do a test that can look at multiple paragraphs, multiple chapters in a little bit more detail. Okay? So I know I just kind of threw a lot at you. What's going through your mind? What are you thinking?
Well, I mean, I'm here and I want to do it. Because I'm going to worry about my other kids, also Rachel's future kids. Is this something she could pass down to them?
So how I kind of talk about inheritance is that if something were to come back as what's called a dominant condition, that typically looking at the family history, it could be a good chance that it's de novo dominant, meaning that it's just a mutation in Rachel alone, that your other boys may or may not have concerns in terms of inheritance or passing on to their children, but something that Rachel could potentially pass on to her children. The other more common type of inheritance that we can see is something called autosomal recessive, meaning that it's something that if you, and what is your husband's name? John, okay. You and John, it could potentially be carriers. The carriers, in a way, it's kind of hidden. So if you think about it, if you have a bike, so your typical pedal bike, if you have two wheels on that bike and you take one wheel off, I don't care how fantastic that front wheel is, you're still not going to be pedaling anymore. That's more like a dominant condition, okay? If you have a recessive condition, think of it like a toaster. If you have two traditional toasters, we're not talking like toaster ovens or anything, but like those 2-slot toasters, okay? If you have 2 slots in that toaster, if you block one slot of that toaster, you can still make toast on this side. So that is kind of more of like a recessive condition. But if you then have, let's say for a child, both slots blocked, then their genetics aren't able to make the proper toast that they need in terms of potentially protein or other areas of the body. Okay, so we can kind of start by looking a little bit more broad, start to narrow it down a bit more, and just kind of take it one step at a time. One last question that I did have for you. Do you know if at the time of delivery, if you opted to do that test where they actually pricked Rachel's heel and got some blood to what's called a newborn carrier screen?
I do remember that, yeah.
Okay. Because that can look at, nowadays, in the state of Michigan, we can look at over 50 different recessive conditions. So where's Rachel born at? What state?
She's born here.
You're in Michigan? Okay, perfect. Do you have any additional additional questions for me at this point? I don't think so. Dr. Buck, did we miss anything that you really wanted us to focus on?
I don't think so. I just wanted to like Zach Morris here and go like third wall for a minute. Like, I think the things that I want you to think about, and please comment too, did you notice how much teaching she was doing there? Like using analogies, following up to make sure like the patient was getting it. This is very different than other healthcare where you just show up, they talk at you for 5 minutes, hand you a piece of paper, and you're on your way. And I think that's again one of the pieces that people like about genetics is it's very much forming a therapeutic bond relationship and sort of walking through that. I don't know, do you guys have anything else about what you kind of just went through?
No, that was great. I don't think so.
Okay. Stuff that Mary didn't know some stuff, right? Because it's been a bunch of years, and so sometimes we have lots of gaps in information where, oh, maybe they did something, and so that's sometimes a challenge too. All right, so the next step in the evaluation would typically be the physical exam. So I'm just going to kind of fill in for you. So coming in and looking at, we named her Rachel. Very good. Mary, is John's your husband's name? That rolled up. So on physical exam, we note that Rachel is very tall, taller than you'd expect for her age. She's also very slender, not like issues with eating or anything. She's got some scoliosis, some curve to her spine, and clearly developmental delay. Just sort of talking with her, you definitely catch that she has some learning concerns. So a starting workup for her might be to look at some genetic testing, which we'll kind of say what exactly that is. And also maybe look at some metabolic testing, so looking at how her body is processing and using energy, because there are a number of metabolic conditions that can cause developmental concerns. So let's get the nurse in here, and she's going to draw some blood for us. Go.
Hi, my name is Stephanie, and I'm from the role of nurse.
Hi, Stephanie.
For this testing, we have to draw samples in 2 different tube types. So plasma amino acids have to be a fasting test and drawn in a green top tube. And then the tube has to be frozen and sent out to a specialized lab for testing. For genetic testing, a purple top tube is used, and that cannot be frozen. If it does, it'll ruin the sample.
Perfect. So we draw our labs, and then they get sent off. I'm sorry, we draw our blood, and they get sent off to the lab. Who is our lab person?
Hi, my name is Megan. I'm playing the role of medical laboratory scientist technician.
Hi, Megan.
I went from the plasma amino acid testing on a Canonet spectrometer. The blood sample for genetic testing is going to need DNA extraction. This itself is a specialized process that needs to be done before any molecular testing can be done. I also have to sort through all the paperwork and shipping instructions for this testing to be sent out.
All right, so not the simplest thing as far as like doctor's office getting blood work done. So the results come back, and from the plasma amino acids show us something unusual. They show us an elevation in the plasma total homocysteine and methionine. So those are 2 specific amino acids. That suggests a particular diagnosis called homocystinuria. And that is a genetic condition, and there is a gene that if someone has a mutation in, will cause this condition. It's recessive, so we were sort of hinting at some of this stuff ahead of time. So we run the gene testing, and it shows compound heterozygous mutation. So compound meaning there's 2 changes, one in each copy of the gene, but they're not the same, so it is heterozygous. So we now have a diagnosis of homocystinuria, and we need to figure out on what to do to get to work treating this patient. So let's hear from our astute physician assistant, who now gets this on their call day. Go.
Hi, my name is Nikki, and I'm playing the role of the physician assistant.
Hi, Nikki.
I got these results forwarded to me as the on-call provider to sort through. There are referrals that need to be made. First, to a metabolic specialist for further evaluation, treatment, and monitoring. The patient also needs an ophthalmology evaluation because there is a risk of dislocated lens in the eye. This condition also puts patients at higher risk for blood clots, so I need to order additional lab work to see if there are other risk factors for that. Lastly, I need to put a screening plan in place for osteoporosis with a DEXA scan every 3 to 5 years for this patient.
Perfect. So we're going to get the patient off to the metabolic specialist, and that metabolic specialist typically has a dietitian as a part of their team. We're going to find out why. So who's our dietitian?
Hi, my name is Andrika, and I'm playing the role of a dietitian.
Hi, Andrika.
This condition can be treated partially with a diet modification.
To help with the metabolic defect, patients can be on a low methionine diet for life. This essentially is a low-protein diet which can be a bit challenging to adhere to. Patients also can increase their dietary folate and vitamin B12 intake to help with the treatment.
Thank you. So that's our dietary intervention, and then we also have some medication options now. So who's our pharmacist?
I'm Danny. This condition can be treated with a medication called betaine. Betaine. This particular medication has the side effect of sometimes causing a body odor. To help with nutrition, since patients are on low-protein diet, they can be treated with a medical formula, which is sort of like a protein drink, but without methionine in it. That is a prescription that often needs to be obtained from a specialty pharmacy.
So those are the things that we did after the patient's diagnosis. So one summer afternoon, your daughter comes in from playing outside. She says she's having some trouble breathing. She's had some asthma in the past, and remember we have her brother with asthma, so that wouldn't be super surprising. We sometimes call that multifactorial inheritance, meaning like things run in families more than they may be expected to. You give her some puffs of your inhaler, but you worry that something else might be going on. So you call the doctor and they send her for some imaging. So who is our sonographer?
Hi, my name is Michelle and I'm playing the role of a medical sonographer.
Hi, Michelle.
If this patient has unusual leg pain or shortness of breath, their condition makes them at higher risk for deep vein thrombosis or pulmonary embolism because of their risk of clotting. I would help image this patient properly, specifically based on the known risks they have if the patient would become symptomatic.
Perfect. It was nothing, it was just asthma. Rachel is alive and well. The family is still, though, they're struggling to process this is all. It's very complicated and they're having some trouble understanding it. So let's hear from our social worker.
Hi, my name is Danny, and I'm playing the role of the social worker.
Hi, Danny.
This patient and her family may struggle with this new diagnosis, something that is a lifelong condition. I can help the family and patient connect with resources to help them with coping. This includes the parents and siblings, as they often have struggles themselves, even though they don't specifically have the condition. I can also help the family with insurance qualification. In Michigan, I can help them apply and qualify for children's special health care services, supplementary insurance, which can help pay for the medical treatment and services this patient will need moving forward.
Thank you. So the family is now in a better place. They're moving forward with treatment and they're monitoring and they're feeling more empowered. And now they're looking to become advocates for this condition and other sort of genetic conditions in the community so that other patients and families don't have to go through the same thing that they went through. So let's hear from our public health person.
Hi, my name is Anita, and I'm playing the role of public health person.
Hi, Anita.
Homocystinuria was added to the state's newborn metabolic screen in 2004, 2005. So this condition wasn't screened for when this patient was born. More conditions are being added to newborn screen every year, but it can be challenging to know what qualifies to be added. In general, there needs to be treatment and there needs to be a somewhat simple and cheap way to screen for the condition.
Perfect. Thus ends the scenario. Give yourself and everyone a round of applause. Stick to your day jobs. None of you have careers in the cinema. So I think, and then we kind of just want to open up for like discussion and questions. Did you see how like genetics was the place that like a bunch of stuff came together with? And I'm not like trying to like inflate what we do, but I think it is unique. And that we take a lot of different pieces, synthesize them, and then what we find sometimes leads to a bunch of other stuff. And when we sort of were asked to come talk about genetics in this context, this is kind of what jumped to mind, is taking all these different areas of healthcare, etc., and seeing how genetics fits into all of them, hopefully in a way that is helpful to you, and also just at least puts a bug in your mind for the future that if something comes up, that we're out there, okay? So that's at least all that we put together formally for today. And I guess the best option would be to kind of open, like, thoughts, questions, reactions. What did you think? What did you observe? Questions for us? That's very generic, but we did, like we said, we didn't prepare very well.
Yeah, so I guess how do you go about helping somebody who maybe doesn't have a history, or they don't know their history because they're adopted, or, you know, like, how do you do that?
We actually have that happen quite a lot. I'll tell you specifically for prenatal genetics, I would have referrals just because both parents were adopted and they didn't know anything about their family history. So on the prenatal side of it, I still offer them just kind of more like universal carrier screening. So who has heard, we already asked the question about cystic fibrosis? Yes, yes. Sickle cell disease? Yep. What about homocystinuria? Has anyone heard about that prior to today? No? There are so many different conditions that we used to just screen based on one set population. So if somebody says, oh, I'm Norwegian, okay, well, we'll give you screening for, you know, A and B type thing.
Homocystinuria was increased in the Norwegian population.
Yep.
We never said that, so that's why it was in
Yeah, so the reason why we kind of asked about that is that homocystinuria typically has about a 1 in 200,000 chance for somebody actually being affected with homocystinuria, not a carrier, but actually impacted. Where somebody who's from Norway has actually closer to about a 1 in 6,000 chance. You can see that it's much more common depending upon ancestry. Well, how many of you have ever had Ancestry, DNA, or 23andMe, or some type of thing like that, and it comes back like 15 different conditions, or not conditions, but 15 different ethnicities that you had no idea that you were part of? Anyone ever done something like that? Yeah, maybe?
Your parents are doing it, right?
Yeah.
Posting on Facebook.
Yeah. So the reason why a lot of times we'll do universal carrier screening is that we're not all just from Ireland. We're not all just a mix of even European ancestry. A lot of times maybe we have some African ancestry that we're unaware of, or Southern European, so Italian or Greek ancestry. So a lot of times we do more like universal screening. When it comes to things like cancer genetics, it can be a little bit more difficult, but for the most part, you still offer very similar testing, but just based on that one individual's history. You don't have as much to contribute to it. And peds, do you guys want to kind of say how you might make a difference? I mean, I don't think.
I feel like the adoption thing is interesting because if you think about it, many people who are adopted, especially international adoptions, are maybe adopted because they have a birth defect. Does that kind of make sense a little bit? And so we often will see those patients with their adoptive parents saying is this genetic? And the honest answer is I don't know, maybe. And you can do genetic testing on them, but you have to do it with a little bit more uncertainty that we might find something we weren't expecting to find, and we could open a real can of worms here that we weren't expecting because we didn't know that every woman in the family had breast cancer, and now you find that this patient has a change in one of the breast cancer genes. You didn't know that from the family history.
And on the opposite side, you might do genetic testing and find out that somebody was adopted and they didn't know they were adopted, or they didn't know paternity was questionable and things like that. So there's a lot of, part of the reason that really pulled me into genetics, specifically genetic counseling, was more of the ethical dilemmas that arise, kind of the psychosocial things that it's not just your straightforward, you have condition A, this is your treatment. Genetics doesn't just impact that one individual, it impacts their siblings, it impacts their children, it impacts their cousins. Has anyone in the family found out that, you guys are still not quite at the point of all having children, but I had a cousin who, she was floored to find out that she was a carrier of cystic fibrosis, and the rest of my family was freaking out. I'm like, genetic counselor here. I've told you guys this for years, that anyone could be a carrier of these conditions, and some are just more common than others. So yeah, it's a lot of the ethical dilemmas that pop up with genetic counseling too. What else?
How accurate are those tests like 23andMe?
So there's different types of what's called direct-to-consumer testing. So there's just the straight up ancestry portion where we'll say, a lot of times we'll just give more of and I can say I've done this before, so I can say similar to my test results, it'll give a range. It'll say, oh, you're anywhere from 9 to 16% Irish. But they're just kind of looking at genetic markers. So a lot of those European countries kind of borders aren't quite set, and those borders have changed a lot over the years. So they might just say Eastern European versus Western European. The other concern, and I'm sure you guys probably gotten this before, but prenatally I would get so many people come in with the 23andMe test with all these genetic markers that we're looking at things like, I'm trying to think of, like increased risk for blood clots or Parkinson's disease or not muscular dystrophy, multiple sclerosis, and oh well, yeah, it says that I have a 50 times risk of having diabetes based on these genetic test results. Well, that's a very, very small picture. That might only be looking at 5% of your DNA. There could be other genetic markers that were not included that are maybe protective factors. We also know that environment plays a huge role on a lot of these conditions too. So yes, it can be helpful, but I laugh every time I see that commercial from 23andMe where the guy's hiking up a mountain and he's like, well, I want to be the best person I can be, so I'm going to look at my genetics. I'm like, that has nothing really to do with it, but.
I think, I tell people it's mostly for entertainment.
Yeah,
at
that's
this
what it
point.
is. Mm-hmm.
They're starting to push in some clinical stuff though, and you have to be careful is probably the right word, because you could get yourself into something like, oh, I didn't know that, and maybe that's not something you were prepared to know, if that makes sense.
I know, sorry.
I have another question.
Yeah, go ahead.
Okay, I mean, genetics is moving really fast. So, in my family, my mother was tested for a condition 20 years ago. So how do you know when to go in and talk to somebody again? Because it has to do with how fast things are moving.
Well, in cancer genetics, a lot of I haven't done cancer.
Yeah, it was
but,
a cancer thing, actually.
Typically, I remember we used to say every 5 years.
Really?
Okay. Yeah, especially with cancer genetics. I mean, 2012, we were still kind of doing mostly just single gene testing,
Yeah.
where now if somebody goes in for history of breast cancer, they're having 10, 15 genes looked at with just one blood draw.
Yeah.
So I would definitely encourage, if it's been more than 5 years. I mean, I even had patients, 6 months went by and a variant had been reclassified and we ended up identifying what the condition was for their child with just a 6-month difference.
That's what I thought. I thought it was like 5-10 years.
So hearing you talk, it was very fluid with the questions you were asking that were kind of difficult, seemed easy, and I'm sure you guys are pros at it now. How long did it take for you to feel comfortable to ask? Like, obviously you have to ask those questions, but to, I don't know, be so fluid about it. You sounded effortless, so I'm just curious how long it took to ask you.
Yeah, go for it.
Some of the questions are still uncomfortable.
Yeah.
Okay, so one thing we asked during the family history, which we didn't hear, is about consanguinity. Does anybody know what that term means?
Mm-hmm.
Okay, so that's asking if your parents are related or not. Okay, and so that's just never going to come out incredibly fluid when you ask somebody that. Yeah, so you just come up with ways that work for you. And then over time, some of the things that are a little more difficult, like how she was educating, that does become a lot easier because you learn how to pitch it to your audience. And I have lots of different ways that I would learn how to pitch it to somebody who's sitting in front of me. So if somebody was a PA, I would pitch it a lot different than somebody who had never had a biology class before. So that becomes a lot easier, but some of the hard things are always going to be a little bit challenging, I would say. And if you just become a little bit more comfortable with it, but I still got nervous in front of patients when I was, especially with positive test results. I always felt a little bit anxious getting on the phone. But it becomes, you rely on your training and it becomes a little bit easier over time.
You kind of have set phrases that are like your go-to things that you say. I remember shadowing different genetic counselors and I always laughed because it seemed like every consult they would say the same thing, but it was, I don't want to say go-to phrases because you do, like Mary said, you adjust what you say based on your patient or who's sitting in front of you. And it's always difficult too when family members might not be upfront with that information and you're trying to, I think people pull me aside and say, so my husband doesn't know that I had 3 abortions before we got together, so do not bring that up in the consult. And just for, she is my patient, so confidentiality is important. So you just kind of come up with unique ways, and it's still, just what we just did, I still got anxious doing it. So it was weird doing a consult in front of this size of
condition. So. And as an encouragement, no matter what you do, you'll get there. You know, it's just, systems are set up, schools, classes are set up in a way that you will be all right and you'll learn what you need to do. And you will have this moment someday where you're doing your thing and talking and it's just rolling off your tongue enough, you kind of like have a meta moment where you step back and you listen to yourself and you're like, holy crap, they really sound like they know what they're talking about. And that will happen, but it takes a long time, and you still have moments and days where you feel like the biggest bozo, and I'm just waiting for someone to come bursting in the door and be like, ha, I caught you, you're an idiot. You know? And that's just part of being human sometimes.
I was just wondering if, as a genetic counselor, are you responsible for the actual diagnosis of like a genetic abnormality, or do you gather the information and then like present it to the primary
So
care?
usually with a genetic counselor, you're working with some type of physician. So for peds, since there is such a physical component to it, you will always have a geneticist present with you. I didn't work with a geneticist, I worked with maternal fetal medicine specialists, so high-risk OBs. So I made it very clear that it was not up to me to, if there was some form of a lethal diagnosis on an ultrasound, that would come from the physician. Now, there were multiple times that a screen would come back or something like a chromosome analysis would come back that confirmed Down syndrome. And everyone would call those phone calls, and those never got easy. So it was definitely something that you eventually become more comfortable with. But for the most part, as a genetic counselor, I'll say that I usually am not the one that gives a set diagnosis. However, there were times when a physician wasn't around, and like, I'm not making the patient wait until Monday to get this information, and it's Thursday afternoon. So, yeah, I actually called quite a few of the results back myself. So we send out to specialty labs, and they would come back to me first and fax or email, and then I would call as soon as possible. Dr. Buck would call out quite a few as well,
But like you went to cystic fibrosis,
Yeah.
and there Mary's working with pulmonologists who aren't genetic specialists. And so she is there as the genetics expert, and so everyone comes to her there as the genetic counselor and says, like, please explain this gobbledygook to people, like, because I can't. So there's incredible job security in the field of genetics because people just don't speak this language. I don't know how foreign it sounded to you just kind of listening to it, but this is what we do day in and day out. And I think you definitely hit that in CF, you know?
I remember as a student looking at some of the geneticists, genetic counselors that I worked with, thinking I will never be able to use the terminology that they're using. It's just like, I don't even know how to pronounce that word. Like, what is that? And then kind of going after like what Dr. Buck said. One day you just kind of step out of the consult and you're like, huh, I think I know what I'm doing. Like, you will get there. And I will even say that there had been a couple physicians that I would work with, and they would be in the room with me during results disclosure, but they would say, do you mind actually saying this? You're a lot better about explaining this to a patient than I am. So, sometimes that would happen too.
For preconception genetic counseling appointment, so then like if there was a strong probability that a child would have a life-threatening disease, is gene therapy an option for them, or like do you guys recommend gene therapy?
So one of the things preconceptually that we always talk about is the technology with IVF, so in vitro fertilization, and they can do what's called pre-implantation genetic diagnosis, which you can extract egg cell, sperm cell, do fertilization, basically, petri dish. I know it sounds odd, but yes. And then you have those embryos, and you can actually just test each embryo to see if they have that condition or not. If they don't have that condition, then you can use those unaffected embryos to implant. It's very expensive, so economically, not everyone can actually obtain that option, but it is something that I have had some families go through. Is that what you meant by gene therapy?
Yeah.
Okay. Okay, because there's new technology where people are editing genes, and I didn't know, we're not there yet, but that technology is coming. So I didn't know if that's what you meant. It's like fixing genes, which exist. It's not.
Genetics is definitely hard because there's not a lot of treatment. You kind of are who you are genetically. But the hope is always if we can figure out why you have something genetically, can you change that, even if you don't change the DNA, can you do something to circumvent that? So cystic fibrosis has come up several times. That's a really good example of cystic fibrosis. I don't know if I get it wrong. It's a problem with salt being moved, and it doesn't move as well in the body with cystic fibrosis. So there are all sorts of new medications that can move that through based specifically on your genetics, like to know which one to give you. So that's why genetics is awesome, because it just continues to explode. We're finding out more, we're treating more, we're giving people more information that's useful to them.
That being said, there can actually be quite a drawback with the amount of information that you're being given, but not quite knowing how to process that information too. So that can be a drawback of genetics. But we catch up rather quickly.
Do we have to stop because
I
we're
would
over?
say,
Or?
yeah. If you want to come talk to representatives after, you may be able to stay a few minutes, and I have our certificate. So thank you so much. And
Thank you very much.